For the next, we invite Dr. Ujjwal Mahajan from NIPER for his talk on inflammatory pathways of acute pancreatitis.
Thank you very much for kind introduction. I'm really privileged to be here and being invited to Indian Pancreas Club. I will be talking about inflammatory pathways in acute pancreatitis. So what is acute pancreatitis? As all of you know, it's an inflammatory disorder owing to the attenuation of pancreas. It's substantially orchestrated by the immune response that orchestrates repair, resolution or fibrotic replacement events. So earlier in morning, Professor Sanja nicely showed autoactivation of the trypsin. That is one of the events for the acute pancreatitis. I will not go in detail about this, but cationic trypsinogen by activation by cathepsin B as well as autoactivation of cationic trypsin, trypsin leads to the attenuation of the pancreas. If we look at the epidemiology of pancreatitis, 1/4 of the first acute pancreatitis episode become recurrent acute pancreatitis and 8% of this become chronic pancreatitis. And if we look at the series of events, so this is a necrosis fibrosis sequence where the episode of acute recurrent pancreatitis determine the course of chronic pancreatitis. So long before, like around 40 years before, it has been postulated that fatal pancreatitis is a consequence of excessive leukocyte stimulation. So whether the severity of pancreatitis depend on infiltrating immune cell, this was postulated. In order to prove this, we looked at we performed a cerebral pancreatitis and we looked at the trypsin activity over a period of 12 hours in the cerebral pancreatitis model. We found a 2 biphasic response of the trypsin activation. Clearly the first response comes from the autoactivation of the trypsinogen inside the pancreas because of the calcium signaling, and the second response we believe occurred because of the infiltration of the immune cells. In order to back this up, when we looked at the histology, we saw the substantial infiltration of the immune cell into the pancreas after 8 hours of the pancreatitis. To prove this further, when we knocked out CD18, which is a B2 integrin protein, which is necessary for the transmigration of the monocytes through the endothelium, we saw there is significant reduction into the MPO in the pancreas as well as a significant reduction in the course of pancreatitis as evident by the decrease in the amylase. To chalk out the immune paradox of pancreatitis, so there is initial damage because of the acinar cell injury that leads to the intracellular protease activation and persistent calcium signaling that leads to the generation of DAMs such as ATP, which leads to the immune response, which further substantiate to the systemic immune response, and after that there is a regeneration of the pancreas. To chalk this out in the course of event, there is a necrosis which is followed by the clearance of the necrotic tissue, and based on the balance of the clearance there is either a regeneration of the tissue or the fibrosis happening in the course of whole pancreatitis. So when we looked at the course of event, acinar cell necrosis is a substantially increase at early immune response, and which is getting clear at the end by the end of the systemic immune response. This is co-aligned with the neutrophil infiltration by neutrophil by secreting TNF alpha aids into the increase into the necrosis of the necrosis in a acute phase of pancreatitis. T cells are associated with the systemic immune response. They are more in the T2 immune response, which is associated with fibrotic and regenerative immune response. Resident tumor macrophages initially proliferate and then transdifferentiate to the M1 macrophages, which are the pro-inflammatory macrophages, which are initially associated with the secretion of TNF alpha, which leads to the necrosis, but later they are associated with phagocyting the necrotic field, so they are also associated with clearing of the necrotic niche. Subsequently, M1 macrophages polarize to M2 macrophages, where they are acting as anti-inflammatory and they are alternatively activated, so they secrete lots of fibrotic factors. So in this course of event, clearly macrophages are found to be responsible for pancreatitis, one of the important player for the responsible for pancreatic damage. In order to prove this, we isolated acinar cells and co-incubated with macrophages. When we inserted them with cerulean, we found that there is substantial increase in the necrosis when they are co-incubated with macrophages. That clearly telling macrophages are responsible for pancreatic damage. To put this forward, we use clotriginate, which is a liposome which can deplete macrophages completely. We saw there is significant increase into the macrophage infiltration, as well as significant decrease in the course of pancreatitis, as evident by the amylase decrease, as well as significant decrease into the MPO. There was no change in MPO because of the neutrophil was not affected by the clotriginate. Taken this further, we use the two model of pancreatitis. One is the mild model, which is repetitive cellular injections, and the severe model where we ligate the pancreatic duct, partially ligate the pancreatic duct, and after 2 days we give one shot of cerulean, so that the model develops acute necrotizing pancreatitis at day 3, which substantially develop into the chronic phase by the day 14. As you can see, there is significant necrosis at 8-hour cerulean model, which is a mild model, but 3-day ligation model, so extremely huge necrotic niche in acute pancreatitis. This necrotic niche is also infiltrated heavily with M1 macrophages at day 3, whereas in mild model there was not sufficient infiltration of the macrophages. This can be also backed by increase in the severity of the pancreatitis course. There was not much of the change in neutrophil infiltration, whereas as evident from the picture, M1 macrophages was substantially increased in this ductal severe model of pancreatitis. Further, when we correlated this with the necrosis, what we observe that as the necrosis increases, M1 macrophages increases, and by the day 14, M1 macrophages polarize to M2 macrophages, and there is a decrease in necrosis. So M1 macrophages actually phagocytes the necrotic niche and that aid into the generation of the fibrotic tissue in course of pancreatitis. So to read this further, macrophages, because of the necrosis and CAMs, become M1 macrophages. They secrete a pro-inflammatory cytokine such as IL-6, beta and IL-12, and then later in the phase of course of the disease, they transdifferentiated by IL-4, IL-13 to M2 macrophages, where they secrete anti-inflammatory response factor or fibrotic response factors such as TGF beta, IL-10. This is also in the morning talk. Professor Saluja showed that trypsin activation happened with M1 macrophages. As you can see here at the 3 day of pancreas, 3 days in pancreatitis models of ductal ligation, what we observe that there is a co-localization of trypsin with M1 macrophages, so such that the necrotic niche is phagocytosed by M1 macrophages, and trypsin B from the M1 macrophages actually activates this trypsin. That's why the second peak into the biphasic trypsin response appear. Whereas when we looked at the CD206, which is alternative activated M2 macrophages, we do not see co-localization with trypsin. So M1 macrophages, which act as a pro-inflammatory, also phagocytize necrosis. So when we look at the treatment of pancreatitis, we see as the time course of the pancreatitis, there is a functional exocrine tissue with recurrent episodes of acute pancreatitis. There is decrease in the functional tissue. So we should aim at targeting the recurrent episode of acute pancreatitis. Our aim should be to increase the functional exocrine tissue. How can we achieve this? So whether macrophage can be act as a target, because as we talked about, macrophages increase the disease severity, and M2 macrophages also associated with fibrosis. But also macrophages need for the cleaning up of the necrosis and tissue repair. So it's the elephant in the room. So we need to reduce the macrophage response specifically in order to prevent pancreatitis. How can we do this? So in order to look at this, we looked at the inflammatory target in acute pancreatitis such as TNF alpha, IL beta, IL6, ICAM, NF-kappa B. Professor Sarja talked about NF-kappa B and IL10. Out of which IL-1 beta we found to be highly efficacious target. Why IL-1 beta? It is a end product of the inflammatory pathway. Inflammatory pathway is expressed in leukocyte, and it is a part of pro-inflammatory signaling cascade. By activation of DAM, NLRP3 inflammasomes form NLRP3 as complex, which bind with the caspase 1, which cleaves pro IL-1 beta to IL-1 beta and pro IL-18 to IL-18, which are highly pro-inflammatory in nature. Whether acinar cell express NLRP3, I have 3 slides remaining. So whether IL-1 beta is or inflammasomes are expressed in acinar cell. In order to check this, we looked at caspase 1 staining, and we saw acinar cell do not express inflammasomes, but they are expressed in the leukocyte compartment such as macrophages. In order to prove this, we looked at IL-1 beta secretion after co-incubation of NLRP3 knockout macrophages and wild type macrophages with acinar cell, and we found that wild type macrophages with acinar cell associated with very high IL-1 beta secretion. So they are highly hyperactive NLRP3 inflammasome pathway. Further, to back this up, we perform the transcriptome analysis, and as you can see, this is as Dr. Joseph said about the inflammasomes, RNA sequencing. It's very tough to get the proper RNA, but nevertheless, what we found out in this co-culture system, we used the macrophages RNA, and we got inflammasome pathway as one of the efficient target. To further back this up, we use the NLRP3 knockout animal where we use the ductal ligation model, and what we saw is there a significant decrease into the pancreatic damage, which is also associated with decrease in the fibrosis, as evident by the Mahajan staining. And then we use the small molecular inhibitor of NLRP3, which is MCC 950, and what we observe that this inhibitor leads to significant decrease into the pancreatitis episodes, as well as the decrease into the immune infiltrations into the lung as well as in pancreas. So to conclude my talk, acute pancreatitis is an inflammation-driven disease. The pro-inflammatory response during episodes of acute pancreatitis regulates how the disease progresses, and the reduced pro-inflammatory response may reduce the severity as well as the tissue fibrosis. With this, I would like to thank. Most of this work is done in Munich, and so I would like to thank my mentor, Julia Mayerli, and my team from Munich, my new team in Naiper, as well as my collaborator. Most of the work is headed by Dr. Matthias Sendler. Thank you very much.
Thank you so much for a lucid talk. For the shortage of time, we'll take just one question. If there are no questions, I'd like to take it. Sir, you talked about M1 and M2, and you said it's directly related to an increase in M1 response, the severity. Have you ever thought of or seen whether it's a proper M1 response or it's a dysfunctional macrophage M1 response?
No, it's so this is in terms of disease hierarchy. I think it's a dysfunctional M1 response. It's not a proper M1 response. So the pancreatitis is the proper M1 response, but secretion of the TNF alpha is the dysfunctionality of the M1.
Thank you, sir.